must say it was a really fascinating session and really exciting stuff happening. I, on the other hand, am a guy with a hammer trying to find nails. My hammer is point-of-care diagnostics for DNA, either DNA or RNA, not sequencing, but amplification, and a bunch of protein stuff, and I've just finished writing a grant for a better serology test for flu. What are the missing pieces in terms of data gathering to address that question of confronting an actual outbreak? Even if we can't predict it, they're going to happen. And the question is, what are we still missing?
Which one of us is? Oh, I got the point. Okay. I got the point for that. So I'd say challenge number one is getting information up from the ground and knowing where to get those either point-of-care diagnostics or the sequencers too. We're fairly good about getting information out from central agencies to key locations in a country, but drilling down to the community level is really hard, and there's absolutely no information coming back up. So I think probably the biggest hurdle to overcome is communication/surveillance infrastructure. So we could be detecting signals from the ground up, but also getting information and tools and technologies back down so you can facilitate any sort of rapid action. I think that's tricky thing number one. And then tricky thing number two is going to be a lot of the sample prep work. So a lot of the stuff that you've seen in our presentations today, they've been successes. When you've got a really viremic Ebola patient, it's pretty easy to get material out of there. But Zika was a lot more challenging. And one of the stories that we don't talk about as much is a recent deployment of the portable sequencer to look at an outbreak of necrotizing cellulitis that was happening. And at the end of the sequencing investigation, everybody was still scratching their heads. We had a triad of organisms, but nobody knew it was a chicken or egg situation. We were like, okay, well, we don't really know what came first. So there's a lot of difficulty in getting a good sequencing story out of your samples. So I think that's probably another big challenge. But yeah, for me, the biggest one is that bidirectional, getting signal that we can act on, and then getting information back down to facilitate action.
So I think there's this nice opportunity with point-of-care sequencing as a diagnostic, where there's going to be kind of market forces where you can imagine if you can do sequencing of a tuberculosis patient to know resistance and what treatment should be, or other situations where you can sequence for treatment, then that sequence from that infection could then be shared to a database and so forth. You can actually get these pooling effects for public health that are actually kind of maybe harder to generate via normal market forces and via kind of you have reference labs waiting to receive samples and so forth. And you could imagine kind of a nice interaction there.
I don't have too much to add to that, but I could imagine that, if we get a little Star Trek-y, that at some point in your future, you cough into your cell phone or whatever device, and it tells you what you have and uploads it to a cloud. And, farther in the future, it'll generate a monoclonal antibody, sniff you with it, and you're done with it. But before we get to that, I think, the communication they talked about is important in penetrating the market. So we have as many diagnostics out there, we get the information back, and we can push back the information. And that's going to require a lot of information architecture management.
I have a question I guess I'm going to answer your question with a question to the experts, and that is there an analogy with cancer where the focus for years has been on the seed, i.e. the mutation that is causal, as opposed to the soil, which is the receptiveness? Is the same thing analogous in infectious disease, and could you look for people who are robust to exposure and find out who's vulnerable, who's robust, and what drives that, and actually change the susceptibility?
Ooh, yes. That's something like I glossed over it in one slide completely, but that's what we're doing with our TB sequencing work in BC, for example. Like I said, we've gone back and sequenced every transmitted case of TB in BC going back to 2005, nearly 2,000 genomes now. And it's all about understanding the public health action. Who are the transmitters versus who are sort of the dead ends? Who are the, it's not so much the receivers of the infection, it's the donors of infection, but who are the ones that we really need to act on? Who are the ones that if we stop transmission from that, and Trevor, you alluded to this too, who are the ones that if we stop transmission, we can prevent a whole bunch of downstream cases? So I think the key there is exactly what we heard about this morning, and getting a whole bunch of different data types about those individuals and coupling it to what we learn about transmission from the genome sequencing. So one of the things that we're doing, for example, is for all of our all of our TB cases in BC, we know who's a transmitter and who's not a transmitter, thanks to this genome sequencing. We also have a record of every single interaction they've had with the healthcare system. So then we say, okay, well, let's just throw a little machine learning at this and say, can we find any patterns of healthcare utilization that are predictive of a TB diagnosis before that diagnosis has happened? So yeah, I think looking in the soil is exactly what we need to do.
A bit slightly differently, and that is in the immune surveillance of the host, rather than, is the information you seek all encoded within the sequence of the pathogen, or?
I thought that might be where you're going, and the reality is for infectious disease, there hasn't been a lot of investigation of the heritability associated with immune response to infections. It's something that's actually been very underevaluated and studied. I think there's been, for certain diseases like flu, there's been a lot of look at some of the historical response and how original antigenic sin and your exposure and prior exposure shapes the way you may respond to it. But how does symptom severity map onto the host exome? What kind of expression do we have? That's something that's been very little studied. I actually have a project that's specifically trying to do that on a seed basis within New York City and trying to get at what is heritable about it.
So related question just on that, so especially from your model, the Sears model, so if you would know the susceptibility of individuals, would that also improve the model? Because in your presentation, most improvement came from the steps 2 and 3 and data simulation and so, but if you would know, if one could, for example, sequence also the genome of everyone that is infected, would that be, is there room for improvement of the model, or are the infections so overwhelming that individuality that we heard this morning doesn't play a role at all?
Well, right now within these models, we don't have enough information as to what's going on to actually try to make those kinds of discriminations to see whether it will improve forecasting. So right now, susceptibility is merely inferred through the data assimilation process. So we can make an inference based on what's observed, the incidence of the level of susceptibilities in the model, and that conflates both naturally acquired immunity and immunization-induced immunity into determining what the susceptibility is. It may be possible, and I alluded to it, this is something that Trevor and I are actually working on, to use antigenic advancement to further that. But I think you're getting at something even more specific, which is if you know that certain people are, and that gets to the notion of like taking precision medicine to infectious agents. If you know certain people are particularly predisposed to have a severe outcome or to be super spreaders or something of that nature, I don't think we have the observations for that yet. That's the problem, and we don't understand the degree to which that's important, the variability individuals have in their contagiousness and the transmissions that they cause, the role of asymptomatic infections. There's a lot we really don't know about some very basic bugs out there. I mean, TB is very complicated, and it has all this latency that makes it, but something as common as the common cold, we don't know how important asymptomatic infections are. If you look at the literature on influenza and you look at the inferences that have been made as to the rates of asymptomatic infection, it depends a bit on how they go about it, but it ranges anywhere from 8 to 80% of infections are estimated to be asymptomatic. You might as well be throwing up your hands at that point. Very poorly constrained.
So I think that you could learn a lot with serology in this case, where in the in flu case, if you just went in and everyone had, there's a particular correlate of protection of HI, hemagglutination inhibition, where if you knew that for everyone against a panel of different viruses, you could well improve your predictions of what's going on. But generally, this kind of issue of serology should play out in other cases as well, where you could predict which kind of, how well viruses will do when they circulate in human population by screening people working in wet bird markets for H7 and 9, et cetera. And so there's a lot of opportunity to understand, yes, that host side. I'd frame the host side more in terms of serology and kind of what's going with the immune system than in terms of actual genome sequencing.
Any questions? Anybody? So maybe related to that, so all your sequencing are targeted, I guess, right? So you couldn't, is there a chance in the future to do non-targeted and then find co-infections and things like that? Or is that not yet in a realm of the possible?
Yeah, that's the clinical metagenomics slide that I put up. Right now, you've got two choices. You can kind of go from culture or amplified PCR products, or you can just throw a clinical specimen, blood, urine, whatever, right on the sequencer and see what happens. And that has a lot of challenges, but that's the area that if you look at kind of who's doing really exciting work in this field, that's, I think, what you're going to see making headlines over the next couple of years is sequencing directly from samples. And that's going to get at some really interesting stuff like co-infections. And we're probably going to see these things like, oh, with pathogen A is always present with pathogen B, or, organism A is only ever a pathogen when organism B is around. But it's a lot of complicated system stuff to work out.
Thanks. More questions? Yeah, Gardy?
So we heard before about the role of digital tools and be associated with social determinants of health and everything. So do one important feature when it comes to the early warning signals is like see behaviors or patterns be shifting towards a completely different direction. So do you have any good examples right now in the fields that can be used to monitor in order to identify early warning signals using digital tools?
That is an excellent question. No, I don't have any ones in particular. I'd say a really effective tool going forward is one that provides, just like you said, it provides a signal, but it also provides the opportunity for kind of longitudinal monitoring, and ideally also something that you can then sort of send messages back down as well. But off the top of my head, I can't give you any current examples of ones that are really working extremely well. Each one is going to be really uniquely tuned to a particular setting. So in some places, Health Map is kind of the best that we've got right now. And so in some settings, Health Map is getting a lot of its information from public health agency websites and news alerts, whereas in other parts of the world where that infrastructure doesn't exist, it's all coming in through news sources. So one website, one platform, but two very different input streams that are providing the signal in different parts of the world. I think it's the best that we've got right now, but I don't know if anybody other on the panel can think of a really cool digital stream that's working now. Future vision, vision to reality.
But as you touched towards like developing versus developed world and what kind of infrastructure need to be in place, except of digital tools, anything else, like it can be molecular markers at the end, or is there anything else in the developing world that you can see that can help us having this longitudinal monitoring?
I think cell phones are the most powerful tool for sure. And that is, There's a really great app out there called EpiCollect, and it runs on a smartphone, it runs on a tablet, and it's a free way of collecting, building an epidemiological questionnaire, really easily distributing it to a number of people. Anybody who goes to the EpiCollect website can, if a questionnaire is being made public, can download it on their phone. So you could imagine this sort of army of community health workers, each of whom has a little smartphone with an EpiCollect survey for a particular outbreak or surveillance activity. They're all doing standardized data collection. It's all being pushed up to the web, and you can make it private or public. So there's some very cool tools out there that leverage the capability of cell phones, but we just need to see them adopted more.
And I think beyond that, you have to go into the ministries of health in some of these countries, and some of the hospital systems need the electronic medical infrastructure implemented. So there are places that are still on paper, there are places that are transitioning away from that, and that level of connection and infrastructure needs to be built up to ensure both clinical and public health practices in those places. And that's still an ongoing issue within the public health community, and it's going to be for some time.
Thank you.
Thank you. Any more comments or questions for the panel? So everybody's looking forward to the poster and food. So we have, let's thank the panel again for an excellent session. And we'll have